afternoon, everybody, depending on which side of the country you are on. I am excited to be here. Today's presentation does come out of my doctoral research, which broadly examined HIA as a participation strategy. And it came about because an important finding of that was how much conflict was potentially avoidable, but due to misunderstandings between and within the planning and public health sectors. So I'm excited today to kind of unpack that and give us a little bit of an idea of what to expect in different types of transportation HIA planning situations. All right. So the outline of today is we're going to do a quick overview of HIA. It looks like most of you, the vast majority of you, are at least familiar with HIA as a process. A quick survey of the field to kind of show why narrow in on transportation planning and HIAs in particular. And then we'll go into the meat of the discussion today of why do we engage stakeholders, who are participating, who's participating in HIAs, and then how can we kind of know what to expect of participation, because there are different types of HIAs. And I'll be using some of my case studies from my dissertation research to highlight those. And we'll finish up with lessons learned and best practices, and then of course questions. So what is health impact assessment? Health impact assessment is a systematic process that takes a variety of data and input from stakeholders and performs an analysis on it in order to predict the potential effects on health. It's also interested in knowing the distribution of those effects within a population, and through that we come to a report which often, or almost always, contains recommendations and often contains mitigation strategies. There's broad consensus about the HIA procedure. It's a very flexible procedure, but these are the steps that you commonly will see describing HIA. You start by screening the project to see if an HIA would be appropriate. Oftentimes there's actually multiple screenings depending on who you're trying to coalesce to get the HIA done. Then you go on to scoping, which is a way of saying bounding the HIA in terms of health pathways and data sources and methodology and who's going to be involved. And then you move on to an assessment. There's oftentimes some interplay between the scoping and assessment, especially if you have a robust advisory and stakeholder engagement strategy. And once the assessment has finished, the recommendations are decided upon and a report is finalized. Ideally, it is presented to decision makers as well. And then HIA is committed to, although frankly due to funding constraints and just the newness of the process, particularly in the United States, to monitoring and evaluating the impact of the HIA itself and then its impact on health. So HIA is one way to ensure consideration of health and decisions made in non-health sectors. And this is a really kind of frustrating point in public health world. So the field of health promotion has recognized for several decades that sectors outside of healthcare provision and even public health in general greatly impact the exposures and the behaviors of individuals. The efforts today to kind of institutionalize that knowledge is known as health in all policies, and health impact assessment is one of many tools to try and inform non-health sectors and pragmatically partner across sectors to influence health. So why is that important? And why does public health care about transportation planning in particular? Well, it turns out that factors like your genetics and gender and even your individual behavior, such as whether you ate an apple today or made it to the gym, or even if you are a smoker, account for surprisingly little variation of health status within the population, less than 25%. Access to health care, which everyone thinks, okay, well, can you go to a doctor? That makes you healthy, actually explains only about another 20%. So that means the vast majority, over 50% of an individual's health is explained by the greater social and environmental context in which that person lives. These are known as the causes of the causes, or the social and environmental determinants of health. And that when you start thinking about that, it means that transportation, housing, working environments, poverty, these factors are just as important as someone's diet and genetics and exercise. If they're so important, that HIA has cited this notion as a foundational principle or value. And if you go and you read practice standards, you'll see that the social determinants of health, or emphasizing that the physical, mental, and social well-being is determined by a broad range of factors from all sectors of society, known as the wider determinants of health, need to be emphasized. And so in adhering to this value, HIA methods should be guided by the wider determinants of health. So because of this emphasis on determinants of health, and also because of a broader integration of health and public health and planning in general that's come from the ground up from largely built environment and transportation, when we survey the HIA field right now, we see that there's been about 231 completed HIAs. It's probably more than that. This is self-reported data that's available on the Health Impact Project website, which is a primary funder of HIAs right now. And when we look at those 231 HIAs, completed HIAs, the vast majority, like 64%, are in the built environment and transportation sector. And we also see that most of them are on projects and plans. You can do an HIA on a policy. We do HIAs on prospective things, and so policies are fair game, but that's a little bit less developed here in the United States. And then quickly, just so we kind of are keeping track of where we're at in the HIA field, this is a map of those 231 HIAs. I think red and gold are, well, red is multiple HIAs, gold I think is funded by Pew, and then the rest of them are just single HIAs. And what is great for me as an HIA researcher is to see that it is spread across the United States. And this is quite phenomenal when you consider that in 2008 a seminal paper listed all of the HIAs in the U.S. and there was a whole 27 of them. And so over the past 5 years we've really seen this take off. So why do we engage in stakeholders, or why do we engage stakeholders in HIA? I mentioned that the social determinants of health are a foundational value, and another foundational value is democracy. This Gothenburg Consensus statement is actually a European import of HIA practitioners. HIA is about 10 years or more ahead of us in Europe through the World Health Organization's push of it. And a group of practitioners and academics came together and listed some foundational values. And they stated that democracy was the right of people to participate in a transparent process for the formulation, implementation, and evaluation of policies that affect their life both directly and through elected decision makers. Generally, in the HIA world, democracy is interpreted to include participatory elements. Meaning that the community affected gets to participate in the HIA and thus the decisions involved in the HIA and the target plan. My research presented elsewhere suggests that the participatory element is actually overstated. And instead, we know that HIA relies heavily on stakeholder input in a stakeholder format, and that's what we're going to talk about today. There are lots of rationales for participation. This comes from poli-sci and planning and general social science literature. But in environmental impact assessment and impact assessment at large, we know that there are normative, substantive, and instrumental rationales for participation. Normatively, we want to reflect democratic ideals. And to the extent that we can include communities, we want to empower them to be able to control their lives and the environment around them. There are substantive rationales such as improving information, and instrumental rationales such as generating legitimacy, hopefully by reducing conflict and increasing the odds of smooth implementation. We know that impact assessment largely circles around this improved information substantive ideal. It's about providing additional information to make a more informed public decision. So the next question is who participates in HIA? Everyone. No, we really do, as a field, want to involve as many people who are potentially impacted by the decision as possible. Generally speaking, HIA doesn't run without the public health sector in it, and it is committed to stakeholder engagement, so we want the target sector, in this case today we're talking about transportation, to be involved. There is usually an effort to involve the government. Sometimes the government's the sponsoring agency of the HIA. Sometimes it's just there because they are the decision makers or the bureaucrats to the decision makers. And we want to hopefully involve the decision makers. We also want to make space for advocacy organizations because they do bring specific interests and perspectives that are important to community health. And then hopefully we do involve the public in some way, although as I mentioned, that's a little bit debated. How do we do this? We generally, anytime there's a full comprehensive HIA, the practice standards suggest that there should be an advisory group which serves to kind of bound this group and help move the HIA forward. We'll talk today about the different levels of input these advisory groups have depending on the nature of the HIA. The very nature of HIA, though, means that participation is challenged by a diversity of knowledge, data, interests, and languages held by various stakeholders. It's a multidisciplinary activity, and advisory committees often contain diverse professional backgrounds, and that diversity includes even within the public health and transportation sectors. This means we can't just automatically assume that there will be common ground. It's going to require good facilitation, and it's going to require a good framework, and this is especially true because we have a diverse society, we have a diverse problem, and environmental health disputes are tricky things to deal with. Advisory groups can be particularly challenging because of a diversity of language. So there's differences of language between transportation and public health that are it's helpful to just call that out right from the beginning. The most obvious example is mortality versus fatality. So public health talks about deaths in terms of mortality. Transportation talks about in terms of fatalities. It seems crazy, but like there can be days lost in arguing about which one's going to go into the HIA report. So just knowing that we talk about it in different ways is important. Similarly, morbidity versus injury. There's some other kind of more loose terms that we just assume people have a working definition that's the same. That may not be. Transportation. People often think of access in terms of access to a highway or road system or a transit system, whereas public health professionals tend to think of access more broadly. They want to think of it as access to health promoting services. Safety is another one. It has a very specific meaning in transportation planning world. It's very tangible. Are they safe? Did a crash occur? Whereas in public health, it's not just about real safety, it's about perceived safety. Do people feel safe? And so I think that bicycle, pedestrian planners who have shown very strongly that perceived safety matters in terms of adoption understand this a little bit better than maybe your highway transportation planners, but it's a big deal to define that up front so that you know what you're talking about. Part of the reason there's such a diversity of languages, there's pretty intense diversity within these fields. You know, if we look at the planning field, we have these land use planners that work on zoning and codes. We have transportation and infrastructure planners and environmental planners, and these three really work together on a lot of transportation plans. We also have design and preservation people who are around, although not so much in this planning realm that we're talking about today. And then we have community development, economic development people. So even in the transportation field of planning, there is great diversity. When you talk about building a highway, that's going to be drastically different than building a bicycle path. So when public health people say, oh yeah, I'm going to do a transportation plan, it'd be wise to figure out who from transportation is sitting around the table. Regardless of who is sitting around the table, the history of transportation planning is largely influenced by a regulatory approach. So in this regulatory approach, the legal context of NEPA, of the National Environmental Policy Protection Act, National Environmental Protection Act, toxicology and engineering plays a prominent role. And we need to be aware of that and know what that means for our particular HIA. Similarly, the public health field is very diverse. The two methodological pillars of public health are biostatistics and epidemiology. These are often applied in environmental or occupational contexts so that we understand the human health impacts of the physical, biological, and chemical agents in the community and workplace. And they often rely on toxicology or the biological expression of environmental agents as an allied field. There are other areas such as community and health promotion, health behavior and education, child and women's maternal health. These are areas that are trying to identify and analyze the social, cultural, and biobehavioral determinants of health and health behavior. There's also in public health this whole other world about service provision, health management, policy administration. That isn't really terribly important to us today, but that's often who is managing big government public health agencies. And then there's a tradition of infectious disease and international public health. So who in this list is involved in HIA? It's hard to generalize, but, and this isn't exactly on top, but we see a lot of the epi, I'm going to go back here, the epi in toxicology as in terms of methods, and we see a lot of the community health and health promotion people in terms of those who are interested, because they want to look at what effects the transportation or other built environment has on specific community health. And so this is a population look at what's happening. It's not about individuals, it's about what the patterns of diseases are, and so that's why the epi comes in, and a little less of the toxicology. So public decisions are tough enough without wondering what professionals are sitting around the table. And a fair question to ask is, what clues are there to help us know what to expect? Harris, Roxas, and Harris are two Australian researchers and HIA practitioners who recently posited that there would be the different types of HIAs would have differing roles for stakeholders and value judgments. So what we should know is that the decision support and advocacy HIAs is largely what is in the U.S. right now. And those types of HIAs are to inform the decision and change the decision. But there's not necessarily there's no regulatory mandate for HIA in the United States. It's also important to remember that this is a spectrum, and things don't fall neatly. In fact, the three cases that I'm going to draw from today are kind of in between in a lot of respects. So it's not neatly boxed. That's the first thing you should know. And then the other thing you should know is sometimes being on the spectrum in between one of these or two of these types is conflictual in and of itself, because the HIA doesn't quite know what it wants to be. So let's start with the mandated HIAs, even though these are really quite rare in the United States. A mandated HIA, by definition, is one that meets a regulation or is embedded within a regulatory process. And the purpose is to minimize negative health impacts, usually through a health risk assessment approach with a slight bit broader look at public health. The HIA author is usually a consultant as hired by a government agency, and it's informed by a very environmental health toxicology approach. And the role of stakeholders in this approach is to provide technical information. So like I said, I can name only 2 or 3, if I'm generous, regulatory mandated HIAs. But one that almost falls in this type is the I-710 corridor in Southern California. This is also known as the Long Beach Freeway. So Long Beach Freeway is approximately 24 miles long, and it's generally 6 to 8 lanes across. It connects the ports of Long Beach and Los Angeles at the southern terminus to the greater metro area by running through 15 distinct cities known colloquially as the Gateway Corridor. These two ports are the busiest in the U.S. and account for nearly 40% of all U.S. shipping trade. The area surrounding this freeway is densely populated, and over 80,000 people live in census blocks with centroids less than 2,000 feet, approximately a third of a mile from that freeway. So those who live near this freeway are by every definition a vulnerable population. We're looking at a 92% Latino, many of those immigrants, and many of those undocumented, low income, lots of children, and environmental conditions, including air pollution, that is bad even by Southern California standards. So in this context, and with the pressure from the ports to expand capacity, especially the Panama Canal going on, Caltrans and the Los Angeles County Metro Transit Authority joined together to lead an expansion of the I-710 corridor. So plans to do this were originally fast-tracked in 2001 with very little input from this historically marginalized community. And when this failed to produce any sort of consensus, they restarted the process, and this time they promised to pay more attention to health and community concerns. So everyone agrees that air pollution is a problem, and the primary problem, frankly, in this situation, but the community is not convinced that the current proposed alternatives are the solution. Caltrans is, I don't want to say ignoring, but trying to minimize the notion of induced demand by expanding the general purpose lanes by 2 additional lanes. So all alternatives are calling for, in addition to 2 general purpose lanes expansion, are calling for 4 special purpose lanes. Although the configuration of those special purpose lanes is up for debate, the community wants it to be 0 emissions from day 1, and there's questions as to whether that can really be accomplished. In order to fight this freeway and several other port-related development projects, a significant environmental justice presence has developed over the past 15 years. And in January 2009, this EJ group joined academic and public health departments to sponsor an HIA training. And 30 people came together and pre-screened and pre-scoped this project as potential for an HIA. And they decided that, yeah, it was right for an HIA and they wanted to go forward. And so 9 months later, the community approached the project committee, the governing body of the project, to ask them to include an HIA within the environmental impact process. The governing body agreed. They wanted to do it. They said, okay, let's do it. But Caltrans was a little bit hesitant, and they are the ultimate decision maker and author of this environmental impact process. And why are they hesitant? Well, because it's an unknown. They don't know what an HIA means in the legal context of NEPA and CEQA. Further complicating things, the HIA was folded in under a separate air quality analysis plan to minimize duplicative effort. And in doing so, the engagement consultant was different from the HIA consultant, meaning that the HIA lost control of the engagement process. And the sponsoring agency, the Gateway Cities Council of Governments, was not particularly supportive of the HIA. So the HIA was completed between June 2011 and January 2012, but was not available to the community for about 9 months later, and there was a lot of disagreement in the advisory community about methodology. All right. So what was this disagreement about? What was this conflict about? I largely believe it was differences in expectations. So on the left-hand side, we have the transportation, air quality analysis people. So a lot of engineers, a lot of toxicologists, a lot of transportation planners. And on the right-hand side, we have public health. This particular HIA was done by the premier HIA firm, Human Impact Partners, based out of Oakland, California. And so the transportation people, the air quality people, were expecting a regulatory risk analysis that was backed by toxicology. And the public health people wanted to use a social determinants of health approach. That meant that they were drawing on epidemiology and equity notions. And it doesn't say that toxicology wasn't playing in, but it was a stark enough difference that the methodology that was being used on the public health side, completely acceptable in the HIA world, was criticized to the point of calling for outside review. That was part of the holdup in why the HIA was not available to the public. It wasn't just the quantitative methods. The air quality people were uncomfortable with expanding the pathways. So traditionally in transportation, particularly big highway plans, you're looking at air quality, safety, and noise. Public health said, wait, we want that, plus we want to know about access, generally defined, plus bicycle and pedestrian improvements. And so this became a point of contention because the transportation side and the target planning side did not understand how to proportionally assign responsibility of some of these softer pathways, or what they viewed as softer pathways. Part of the reason why we're in this situation is that, you know, transportation planning is largely institutionalized by the NEPA process. And then there's a couple specific things about the NEPA process that made the HIA difficult to do. One is that the NEPA process requires you define your alternatives as you enter into the environmental process. And once you define those alternatives, you can't really deviate. Public health is like, oh, the obvious alternative is not listed here. Let's just reinsert it in. And they don't realize that that's not really legally possible. And now you're into like a mitigation world, and that is politically difficult. The other thing that's really difficult about the NEPA process is that there are timing and data confidentiality concerns. So in order to get the data over to the health side, you need really good data agreements. And oftentimes planners are running right up to the very end on these models, and there's no time to run the model for health. And so when you go into this, there needs to be some upfront planning of how are we going to get enough time to do a health impact assessment that is quantitative, because that's the other part, is that transportation planners think that they want that quantitative analysis. And then finally, you know, the technical advisory committee is great, but it meant that the public health side did not have control. And in a system where they're used to working with public, including advisory groups, this was problematic. So one of the reasons this was problematic is most public health practitioners doing HIA in the U.S. are used to a decision support model or an advocacy model. So in a decision support model, you're informing the decision, your purpose is to maximize health and minimize disparities, and you're seeing this done by looking at environmental health, but also about the social determinants of health and health equity. It's often done in government agencies, sometimes in the nonprofit sector. So what do we mean by health equity? I think this is worth defining. It's a foundational value of HIA and something that transportation planners should be clear about. HIA advocates for health equity, meaning that HIA is not only interested in the aggregate impact of the assessed policy on the health of the population, but also on the distribution of the impact within the population in terms of gender, age, ethnic background, and socioeconomic status. In the U.S., socioeconomic status means spatial distribution as well. We're interested in the vulnerable populations on the public health side. And this kind of applies to a different decision-making world. We want to maximize health and minimize the health disparities. So that is what public health is going to advocate for, are those two things. Briefly, a good case of this, an exemplary HIA, is the Clark County, Washington Bicycle and Pedestrian Master Plan. This is a pretty straightforward active transportation plan that focuses on physical activity as a way to reduce disease. The HIA was very helpful in this plan because it expanded the types of health pathways considered. For example, proximity to healthy food was included once the HIA brought it to the attention of the planners and advisory committee. This HIA is interesting in that it did not have a separate advisory committee, and largely I would not recommend that. But the HIA author stated this was a pragmatic decision based on a tight timeline, and it seemed reasonable because there was a good, long-standing working relationship between the community planners and the public health department at the county level. A notable finding from this case is that even in the face of limited community interaction, the HIA filled important participation gaps and expanded the public's considered. For example, the citizen representation on the advisory committee was, and this is a quote, self-selected, old school, mainly male, Caucasian, older recreational cyclists who focused on, I want to get from point A to B, and you need to learn how to ride safely. So if that's who your public is there informing the decision, how do you balance that out? How do you account for the pedestrians, the utility cyclists, the commuters, and the future users? Well, the HIA played a heavy role in doing that. They drew from the active living literature and through a geographic emphasis also demanded that socioeconomic status was accounted for both in the plan and in public works criteria for sidewalk infill. Why did it work so well? I think it's primarily good collaboration. The planning and public health had a good working relationship, and planning committed to and allowed public health significant time on the advisory committee on various times that they met. The plan was also not terribly contentious, and we could talk about this on a whole other day, but the notion of a health promoting visionary plan is a lot easier for planners to stomach sometimes than a risk reduction plan. So if you're in this risk reduction realm, you're thinking about the legality of it, whereas if you're in this health promoting realm, it's a lot easier to fold in the health stuff because it's all good. Hooray, yay, we're doing good things. So the next type of HIA I want to discuss are advocacy HIAs. Now advocacy HIAs, instead of just informing the decision, they want to advocate to change the decision. The health purpose usually is to minimize disparities and maximize health, and the emphasis on minimize disparities. These are performed generally by health nonprofits in partnership with community-based organizations, and the role of stakeholders is more of a guidance role. While they are pretty uncommon in the far right-hand column, there's also community-led HIAs. This is like advocacy HIAs, but even stronger. And so we have increase in community control, social and health equity are the primary concerns and primary things that are informing the HIA. So I have a really good example of a case that kind of toggles this advocacy community-led HIA, the Lake Merritt BART Station Area Plan. The BART station that we're speaking about is in the center of the circle, and it's in Oakland, California. It's right outside Oakland's Chinatown and to the east of Laney College. So nearly 15% of the buildings in this area are residential, nearly all multifamily, and there's a huge government presence. I think most of the gray buildings are government, like dark gray buildings. And so I think nearly half of the area is publicly owned. So this is a TOD, transit-oriented development plan, where the planners want to address some circulation issues, and they want to lay out kind of the zoning and vision for turning this into a greater transportation corridor and hub. And equitable planning is really difficult in this context because planners are trying to balance Laney College, this community college, with this great redevelopment potential, a significant Asian community, including immigrant, refugee, and Asian Americans. Oakland's Chinatown, I swapped that, is the third largest in the country and may actually be the largest live-work Chinatown. And it's a highly concentrated and impoverished minority community. 1/3 of the households make less than $15,000 a year. This community is also heavily dependent on language-specific services. So, a significant point of contention in this plan is the redevelopment of 3 publicly owned blocks at the center of the planning area that were taken eminent domain in the 60s to develop that BART station. Two of these blocks have been used as public spaces for culturally relevant activities, such as Tai Chi, ever since. And they're not very glamorous public spaces, but they're well loved by the community. From 6 to 10 a.m., these blocks come alive, and many of the elderly Asian population, almost all of color, come to exercise, play, socialize, and acculturate in these spaces. So this is really fascinating. You know, it's whose health are we interested in? Those who are already using this space, or do we want to turn this into transit-oriented development? You know, walking and ped and transit's very healthy as well. And how do we sort through this? So despite the best efforts of the city, community-based organizations were really nervous. So 6 organizations, 4 of which were drawn from a Chinatown coalition, initiated and controlled every aspect of this HIA. When they got together, there were a couple things that were immediately clear. The first was that they wanted a separate but parallel HIA for advocacy purposes. They were not willing to ask, even if it was offered, they were not willing to subsume their HIA under the official planning process because they wanted to be able to use it for their advocacy purposes. The second thing that was immediately clear was that they were all committed to a social justice approach, but they were struggling to define the scope of the HIA because they had different languages and advocacy priorities. So we had some housing, some transportation, some true EJ people there, some health provision people there, and they weren't quite sure how to get to their bottom line. The social determinants of health really helped them work through that and decide how to come to what the HIA should include and what was the priority for that community. The HIA was really successful. The advisory groups approached the senior planner very early in the process, and they were filling out, okay, what can we do to maybe have this HIA in the view of planners over here at the City of Oakland. And several people told me how the senior planner whipped out a schedule and said, I would like input here, here, and here. And the HIA people said, oh, okay, we will do that. And even though it was far earlier than they had anticipated finishing the HIA, through a series of memos, they were able to give input at the best times possible. And I think both sides really appreciated that. And you see that the language from those memos enter into the official planning documents. So we know that that was an effective and influential way to do that. So what are some lessons learned? You know, obviously there's no one right way to conduct stakeholder engagement. I've told about things that have worked, things that haven't. I've told about integrating it completely within the target planning engagement process. I've said keep it completely out. I think you have to be pretty strategic about it, but there are some lessons that seem to cut across. First is that conflict with HIAs often align with the type of plan, so that health promoting versus risk reduction needs to be thought about carefully. The scale of the plan, frankly, big, huge highway expansion projects have massive environmental impact processes behind them, and if you don't have the resources to engage that, you probably should not be doing an HIA. And the previous ongoing relationships between planners and public health matters a great deal. We know that good facilitation can go a long way. HIA is a way to address a specific type of interest in transportation planning. It's a way to address health and the concerns about health. Both disciplines have norms for facilitation. Public health tends to be a little more participatory, but either discipline norms are likely sufficient. They just need to be followed. The third lesson is that professionals misjudge other professionals within and between professions, and they assume uniform interest, and this gets them into trouble. It's that whole toxicology versus epidemiology, what does health really mean, or assuming that someone working on a highway plan is appropriate for talking about bicycle design. You just can't do it. You have to learn what their specific type of professional expertise is. Transportation planners, to minimize this conflict, really ought to try to understand who is performing the HIA, because this hints at the type of HIA. So use that HARIS 2011 typology to kind of think through what type of HIA am I getting into. And that can go a long way for setting up appropriate expectations. If it's a government, another government agency that you are working with, that is going to be a decision support HIA. If you're working with a nonprofit, it's going to be more of an advocacy HIA. They have the ability to do that, and they're going to use that. The biggest thing that I think transportation planners can do in order to understand the goals and expectations of public health professionals is to learn about the social determinants of health and health equity. Those are the foundational values that really drive health impact assessment. Once you're in the midst of the HIA, we need to be clear about data timelines. So how are we going to get the data from the planners to the health people and do it in a way that they can actually get the analysis done? I didn't talk about it much today, but GIS data is incredibly helpful to public health practitioners because, and particularly for safety, because they are interested in spatial disparities. HIA practitioners, so public health professionals, really need to try to understand the regulatory constraints and ask about health partners when they get into a partnership with transportation planners. Transportation planners may assume, yeah, we've worked with public health, but if they've worked with primarily toxicologists, you're in a different ball of wax than if they haven't. And so if their primary exposure to public health is toxicology or environmental quality, environmental perspective, they need a little more hand-holding in terms of understanding the social determinants of health and health equity and getting everyone on the same page. Be flexible about the products. So the Lake Merritt case is really obvious that, you know, it's not the HIA product itself that is most influential, but oftentimes the interim products are just as influential, and so be flexible about that. Be flexible about the timeline. We know that scoping is the ideal time for stakeholder engagement. You need to budget enough time and resources to do that. Even very experienced HIA professionals are not budgeting enough time. And beware of giving up control of the HIA advisory committee. You know, integration with a target plan engagement strategy sounds like the easy way out, and it might even work. The Clark County case shows that it can work if there's a lot of trust and a true partnership. But if you don't have that ongoing trust and commitment and partnership, you'd be wise not to agree to that. Best practices in general that I think needs to start to be adopted within the HIA world are as follows. There needs to be a stakeholder engagement plan. After this, there will be some resources posted, and there is a stakeholder engagement guidance document out there, and it calls for this, but you need to formally think through how are you going to engage stakeholders and which stakeholders and how are you going to do that. We need to be meeting with planners very early on. So as soon as the idea of an HIA comes up, don't get too far into it before you talk to the planners. You need to be asking about the timing of the process and specifically ask, when would they most appreciate input? Because that is the time in which you're going to have the most influence. Ask about and attend each other's advisory committees. You know, we're all busy professionals and it's easy to silo. Let's break down those silos. When you're asking, ask about the composition of the advisory committee. Sometimes you can even adopt a core group on both. Ask about the purpose. Ask about attending, and make it a point to be there. Once you're there, do not assume that one planner or one public health person can represent the entire field. I can't tell you how many times in my professional practice I show up and they're like, oh, health is already here, and they've invited a health care provider, so a doctor. That's not the same as another public health professional, and we have to think that way when we're inviting transportation people. We can't just invite the highway engineer and assume that the bicycles and pedestrians are taken care of. And so really think through who you need to have there and make sure that they're all represented. So that's all I have, or that's more than I have today. We are at questions, and I haven't been keeping track of it, but my students have.
Sure. Thanks, Nicole. So for those viewing the webinar, please feel free to continue submitting your questions if you have them in your question pane. We do have a number of questions. So the first one is, can you talk specifically about what skills and knowledge public health professionals bring to the HIA process that other professionals generally do not bring?
Sure. Public health professionals bring a couple things that I think are really important, both procedurally and in terms of defining actual impacts. The first thing is that they have a really broad view of health. And that broad view of health, understanding not just the safety impacts, but the real and perceived safety, access to health promoting resources, the physical activity versus the air pollution. They have this very interdisciplinary look at what impacts community health. And that aligns with community wants. And so transportation planners would be wise to leverage that in terms of getting a little bit better handle on what the community really wants out of a transportation project. They're also, particularly those in community health, they're very well trained in facilitation. They're very well trained in understanding how to roll things out with the community in terms of programmatic stuff, and so that can be leveraged as well. And then finally, they're the ones keeping up on this literature, and it's moving really fast. Our knowledge about air pollution and cardiovascular events, our knowledge about physical activity, is there a dose response, is there a benchmark? Those things are moving really fast, and it's, I think, difficult for planners to keep up on the cutting edge, and public health people will be on that cutting edge.
So here's another question. What are the specific social determinants and equity factors that transportation planners should learn about?
So I think the main social environmental factors that transportation planners should always think about are, first of all, physical activity. So it doesn't matter if you're on the highway planning side or if you're in bike ped. The reality is that the ratio of cars to alternative modes of transportation drives the amount of physical activity that is happening. This is a huge burden of disease. It's a driving factor in disease and deaths right now in the United States, and increasingly so. Physical activity drives obesity. It has a protective effect in and of itself, and so that is something that needs to be looked at. That pathway of using transportation to crowd out or provide physical activity. The second one that NEPA requires looking at is this notion of air quality. This literature is changing really, really fast, frankly. The PM 2.5 from diesel and other air toxics aren't just about asthma anymore. They're about cardiovascular disease. They're about some cancers. They're about quality of life, and all those things are important. And then, of course, traffic safety. But I think it's a broader look at traffic safety. So we know, especially if you're in the bike ped world, you know that perceived safety is really, really important, and that design matters. And so public health professionals are really attuned to the notion that the environment, broadly defined, impacts choices and impacts behavior. And so knowing what makes for a safe, public health doesn't want a minimally safe environment. They want a maximally safe environment, one that encourages active living.
Okay, great. So what about just the broader HIA question? Can't HIAs just use information from the planning advisory group and the public engagement mechanisms?
There are examples of that happening, and I think in some ways they can. So if if as an HIA professional you attend every public meeting and you mine what's being said about health, you will have a really good feel for what the community wants. There's a couple things you run into with that. The first is you could poorly identify that. You could, who shows up at the meetings isn't necessarily representative of the entire public. You could possibly run into an issue where even if you do appropriately define the health interests, that you struggle to implement it or get support for it. And so, HIA is a process, and a lot of the effectiveness of HIA comes from that process. And when you don't have an advisory committee, you don't have that process. And if you have an advisory committee that is only the target plan advisory committee, you do run a real risk of co-option.
So we do have one last question. This relates to stakeholder engagement, which seems to be very important for developing HIAs and can be difficult to do well. So what is the biggest challenge to stakeholder engagement in HIA?
I think the biggest challenge is developing those relationships and getting to a shared language. So in my studies, is what we see is that a lot of times if you can get people there, there's crowded professional agendas and we're all busy people, but if you can get everyone around the room, oftentimes we all want the same thing, but we don't know how to talk about it. And so it's really easy to say, okay, we're going to have 3 one-hour meetings spread over 4 months, and that's going to be the stakeholder advisory committee engagement. And in some cases it might work. It's going to be difficult, especially if the group is new to each other, because how we talk about health, how we talk about equity, how we talk about what matters, how we talk about safety, that's going to vary around the table. And so I think that the biggest challenge is just having the time and the resources to work through that shared language and develop that shared language.
All right, great. Thanks. Thanks, Nicole. This concludes our webinar. Thank you for joining us today. We are looking for your feedback so we can continue to offer relevant webinars in the future. So be on the lookout for an email with this information and a short evaluation survey that we will send out to you. We will also be in touch with you regarding professional development credits if you are tracking that. Also, just for your information, you can view other IBPI professional development offerings on our website at www.pdx.com.